Good morning and welcome to the AWS Education Research Seminar Series. This morning we're going to be discussing artificial intelligence and machine learning in pediatric biomedical research with Professor Judith Dexheimer. Dr. Dexheimer is an Associate Professor of Pediatrics at Cincinnati Children's Hospital Medical Center and the University of Cincinnati. She's a clinical informaticist working on the development and implementation of machine learning applications into clinical care. Her research focus areas include machine learning techniques, real-time patient identification systems, disparate data merging, and applications of clinical data. If you have any questions for Judith, as she likes to be addressed, during the session, please feel free to enter them into the questions queue on the GoToWebinar tool. We will reserve the last 5 to 10 minutes of the session for a Q&A. And without further ado, I'm going to go ahead and hand the mic over to Judith. Judith, please take it away.
Thank you very much, Marcy. I'm happy to be here today, and I'm happy to talk about things. So my goal over the entire presentation, so 45, maybe 50 minutes, is basically to get you as the audience interested in machine learning and informatics. It's a rich field. It's got a lot of future with a lot of different innovative possibilities. And I want you to see that it could be a lot of fun and that it would be a great thing to start researching in. So I want to start with basically some definitions. Perfect. So I'm going to start with the title, and I'm going to define all of the key terms in the title just to make sure we're all on the same page. So the first thing I want to define is artificial intelligence. So it's basically intelligence demonstrated by machines in any device that perceives its environment. Machine learning, which is an application of artificial intelligence, including data mining, to capture relationships between variables and use them to make predictions. And these are kind of the main technical terms that we'll go through. And then, of course, there's pediatrics, which could colloquially be described as everybody under the age of 18. But really, it's a medical field that practices the care of infants, children, and adolescents. And so then the big last term is really biomedical informatics research. So I took this definition from the American Medical Informatics Association's official definition of informatics. So biomedical informatics is the interdisciplinary field that studies and pursues the effective uses of biomedical data, information, and knowledge for scientific inquiry, problem solving, and decision-making motivated by efforts to improve human health. But this isn't what you really say when you talk to people about informatics. So the first thing to know is that biomedical informatics research covers bioinformatics, clinical informatics, medical informatics, health informatics, pretty much everything you could put under this general umbrella. But I think the question really is like what do you answer at a party when someone asks what you do? And so in the simplest terms, I say that I work with the hospital medical record system and healthcare providers to improve patient care and to help improve the use of the hospital medical record system. So which leads to the next most obvious question, which is, what's the hospital medical record system? Well, that's an electronic health record. And that's okay, because then you can ask, what's an electronic health record? So the electronic health record is basically a digital repository of patient and population data. So on the large overview side, there are more than 300 EHR vendors in the United States. I've listed some of the main ones here. Between Epic, McKesson, Cerner, and Allscripts, that covers about 80% of the EHRs in the United States. And so they're very widespread. More than 75% of hospitals have an EHR in use, and more than 80% of pediatricians report using an EHR in their practice. And for us, it's our primary source of data for studies. However, it was really designed for clinical care, documentation, and billing purposes. And it is used for all those things, but it's also used for research and some of the administrative functions. And so what's in all of this information besides I looked at my own record, I saw how I did that day, I saw what I'm supposed to do after my visit. So there's two main types of data in the EHR, and the first one of those is quantitative data. And these are structured data. So things like vital signs. So when you go in and you have your temperature taken and your blood pressure taken, these are stored in your EHR. These are structured. Another is your acuity level. So when you visit an emergency department, you typically get a score of 1 to 5 about basically how sick you are when you walk through the door. 1 being the sickest, 5 being the least sick. And then finally, another example of structured data are your billing diagnoses. So why was it you were really there that day? What was billed to your insurance company at the end of the day? The other piece of data in the EHR, which is what I primarily work with machine learning, is the qualitative data, and it's your unstructured data. And there's a lot of this. It represents, which I'll actually tell you 2 or 3 times, about 80% of the data in the EHR. And the first set of these are your clinical notes. So anytime someone talks to you when you visit the hospital, they write a note to document what they did. So when your nurse comes in your room to check on you, he or she goes back and writes a note and documents what they did and why. At the end of your visit, your physician or your provider writes a note saying, this is what we talked about today, this is what we recommended, here's some of the structured data, but this is how my patient's doing, and here are the logical next steps. If you call the hospital, you get yet another one of these recorded and free text sheets of information. So then it's not just clinical notes that way, but also if you have a medication order for any medication and your provider types in extra information about it, there's another piece of unstructured data. If you have a PDF form scanned in from a prior hospital visit, there's some more unstructured data, and those discharge instructions, where they provide and they say, please take these medications, please follow up with the following people. All of these are actually free text when they're stored in your medical record. So how much data is it really? We are one institution, and we are a pediatric institution. We have, on average, about 1.3 million patient encounters. We have about 3.68 million encounters per year, so the 1.3 are distinct patients. And in our electronic health record, we have a total of about 45 million patient encounters listed. Of those, we have 2.1 billion rows of flow sheet data. In our EHR, these data are from 2009 to 2018. Flow sheet data are typically your structured data, and these are all stored in the EHR. And total, we have 8 terabytes of data being stored. 3.2 terabytes of those are for clinical data only and represent clinical care and things that are happening. And the other 5 terabytes of data are research-based, and they represent studies, they represent research that is across different institutions, but they are all things we are storing, we are maintaining, and that we are able to access. What's important to note here is that we are only one hospital, and we serve the greater Cincinnati area, but this is only one hospital, one state, and there are several other children's hospitals in our state. So the take-home message from the last couple of slides is that there's a lot of data out there in the world. So there's large amounts of patient data stored in an EHR. And with the widespread digitalization of healthcare, we actually have an exponentially increasing amounts of data from a bunch of different sources. And it's a potentially rich source for research and data mining. An important thing to remember that I've already brought up once before, here on the left-hand side, 80% of health data is unstructured, and that's stored in those clinical notes. And while you can sit and read all the information, that's a lot of data. So why aren't we already doing a lot of big data projects with all of these data? And why aren't we already analyzing all these data and changing patient care and making the world a better place? Well, the short answer is that we are. We're just doing it piecemeal as we go through things. So the goals, kind of as the overarching for the rest of the talk, is to understand the role of artificial intelligence and machine learning in research with the EHR, to explore some of the unique aspects of conducting research and work in pediatrics with biomedical informatics, and then to examine what's being done now with machine learning and what might the future hold for everything. So why do we do this? And the important thing about this is the data complexity. We've talked about how much data there are, and they're all there, they're all available, but we need to make use of all of them. So with those 80% of unstructured data, they contain rich and valuable information for everything, but the amount of information required for a given decision is just too much for one human to take care of. And that's where the computers come in. We can help people make better decisions with more information, with the idea of improving care. So I want to go ahead and present to you what's the fundamental theorem of informatics. The goal of informatics is that the human and the computer is going to perform better than the human alone. The fundamental theorem of informatics is not that the computer is going to perform better than the human, but that we can aid someone and we can help them make a better decision. So what we want to do is help the users make a more informed decision and basically ultimately improve patient outcomes. So, but you say I have an EHR, or I use a word processing program, or I use email, and it's actually not that easy to use. It's not user-friendly. You suffer from alert fatigue in both your EHR and your phone. You get text messages, you get reminders, you get everything under the sun. Like you really want research to be great, you want everything to be happy, but you also want it to be really easy, simple to use and do exactly what you want. Exactly like what happens when you want to upload a new picture to Instagram. So why isn't the EHR exactly like Instagram right now? Luckily, I have a comparison for you. So here on Instagram, there's really only one type of user, and that's fine. So you have your own account, you can do everything you want to do with it. You have a couple of different types of data. You can have text data, you can have video, you can have images. You're in control of all of your own data here. You have a lot of features. You can upload a photo, you can message someone, you have a nice, clean, user-friendly interface. You can add hashtags so that it's easier to search things in the future. And you have both a chronological or an algorithmic-based feed, depending on what Instagram's doing today, so that you can kind of see what's happened with you and your friends, etc. And then APIs, which are application programming interfaces, exist for third-party integration. So they do technically exist, but the idea is if you said, I don't like the way Instagram shows me these things, I want to use this other program to get out the same data, you can do that. And so you control your own data. You have privacy. You can choose what's posted to your account. You can ask for an image to be removed. You can do something if someone else tags you in an image you don't want to be in anymore. This is great. Instagram is wonderful. It's easy to use. So how is the EHR different? So first, let's do the number of different user types. So there's conservatively more than 100 different types of user in the EHR. As far as providers alone, you have medical students, you have residents, you have fellows, you have attendings, and then you have different types of provider for different areas, and they each have their own different view to help aid in their workflow. Then you have nurses, and nurses each have their own type of providers as well with the same idea. You only want some people to be able to write orders. For example, I want my provider to be able to write a medication order for me, but I don't really want researchers or administrators to be able to write a medication order for me. So those have to be taken care of. And so what about the data that are stored in the EHR? I also went a little over conservative here and said there were at least 20 types of data in the EHR. There are in fact more, but just on the baseline, you could have a text-based note, you could have those structured data that are vital signs, you could have your medication orders, you could have the check boxes that are just there for charting to make sure things got done. You could have drop-down menu selections, you could have images, you could have PDFs, you could have all sorts of things being stored. So these are a lot of things, and nothing is insurmountable. So now we've still got a lot going on right here to not make it quite as easy to use. But what about the number of features that are included in your EHR? As I kind of alluded to earlier, you can have notes, you can have orders, you can have your past medical history, You can have an in-basket message where your providers message each other about your care, or reminders could be sent to your provider about you and about your care, about what needs to be done in the future just to help them out. You have a searching functionality, not entirely unlike Instagram, except no hashtags. You have a chronological feed, which is a patient timeline. There we go. You have an interruptive alert that comes up in the middle of your presentation. What a great example. Thank you, Microsoft. So you have searching functionality. You have a chronological feed, so you can go back through and say from the time this patient entered the emergency department to the time they left, what happened, what different courses of action were taken, and who came in contact with them. And then finally, you also have APIs for third-party integration to get data into and out of the EHR. And so what's another option, which is privacy? So there are audit logs. Just the same with, you can track who accessed your record, every single click, everything you do in the EHR is stored. And you, the patient, unfortunately, have no real control over what information is in your record. You can send a message and say, I don't believe this is correct, and this gets logged in your record as well, but this doesn't actually provide any updates to your record, and it doesn't say remove a diagnosis that you, the patient, may not agree with. These are all wonderful, but there's actually more things that the EHR has to deal with, including regulatory compliance and safety issues. All of these things together combine to say why the EHR front end isn't necessarily clean, beautiful, and easy to use. It's trying to do a whole lot of things. And so now hopefully I've convinced you that, wow, there's a lot of stuff in there. What can we do to make it easier for users? What can we do to access some of those data, pull important things together, and then provide it to users so that they can see it when they need it? So this is where I'm going to give the easiest, simple overview of machine learning. So what we could do with all these EHR data is we could use machine learning. We could take a bunch of the complex information, we could filter it down to what's the most important in the most number of patients, and then we could give it to the providers and say, you know what, I think you should consider this. So here's my sample explanation. Here you have two sets of labeled pictures. One stack of pictures is labeled cat. One stack of pictures is labeled dog. This is supervised machine learning. Someone said, these are cats, these are dogs. And then what we did with these things that I have helpfully called cheese graters here in the middle, these are really the machine learning input layers. This is really the model that we created and trained to tell the difference between the picture of a cat and a picture of a dog. So then when we show it a brand new picture of a cat that it's never seen before, it goes through all of these layers and the output is, what is it? And in this case, it's a cat. The machine is correct. Great job. We've classified it correctly, and we have used machine learning on a brand new set of data based on something we've trained it on. We're going to talk about primarily natural language processing, which is part of why I've stressed how important it is that most of the data in the EHR is in unstructured notes. So natural language processing, in the briefest sense, is using a computer to get meaning out of text-based data. So I'm going to show you, similar to the picture before, what it is we do to create natural language processing, to create a new algorithm and then to apply it to new situations. And so this first picture is, the first thing we do is create a data set. We talk to people, we create it different ways, we pull records, we pull data from the EHR, we create a great, robust data set that includes everything we need. Then what do? Then we create and train a model. What you see down here on the bottom half of the middle screen is an example of annotation. This is a clinical note that a human has gone through and annotated and said, these items are important for this thing, these items are not important for something else. And so we do this with a subset of notes. And again, this is the supervised machine learning. And then we have two sets of outcomes, cases and controls. The top half of this image has the cases and controls. We have blue and we have red dots. What we do is we put this into our machine learning algorithm, and then we try to draw a line. That's what's happening in the box that says feature space. And we try to differentiate so that when we see someone brand new, we can tell whether you're a blue dot or you're a red dot. And from this point, of course, then we can make predictions on future data. So we can say, we have this whole new set of data. What is it that you are? And then we can say, based on our past information, it turns out you're going to be a red dot. And then we can evaluate whether or not we're correct, and we can give this information to providers. So with NLP research, so natural language processing, it's machine learning that's concerned with the interactions between computers and natural languages. And how do we get the computer to understand clinical notes? And so let's do a couple of caveats about why it's difficult. The first one, syntactic ambiguity. This one is my favorite example, and it's time flies like an arrow, fruit flies like a banana. You, as a human, know the difference between these two sentences. The computer does not, and we need a way to teach the computer what the differences are when we look at these two types of things. A second one of these is basic spelling. We're looking at free text notes, and people make mistakes sometimes in spelling when they're typing. You know this from autocorrect. Everyone has used it and loved it and hated it on things like their phones. In this case, this is another one of my favorite examples because it has so many meanings. The executive boardroom does get the meaning across, but it's not necessarily what we want to have happening here. The next is negation, and this is an example from Google from an idea of clinical negation. So here's an example. So the first one on top is there are no issues other than her indicating that she might commit suicide. There is clearly a negation here, and there's something else that's important. And then the second one is that he continues to deny any suicidal thoughts and is happy to come, etc., etc. These two things mean very different things. However, there's a lot of different processing that you, the human, go through before you say, oh no, the first one is someone I might be concerned about, and the second one I'm not. And then the third thing, of course, is just data cleanliness. So you have a lot of data and it was not collected for research purposes. And so it's wonderful for clinical care, but it's not necessarily wonderful the way it is for research. So what are some of the overall challenges with basically all database projects? One of them is a lack of access to shared data. There are a lot of data out there, but there aren't a lot of shared data that we can openly access and do everything with. There's a lack of annotated data sets. In that previous slide, I showed you that we needed to annotate a lot of our data sets to be able to make predictions based on them. And there's no standards for annotation. So even if we annotate all of our data sets, we won't necessarily be able to share them with another institution. Lots of data, of course, is not always good data. So more is not always better. And then one of the issues is provider acceptance from the machine learning recommendations. You need to have your provider, your end user, someone included at all times from the very start so that they feel comfortable with the recommendations that a computer is providing them. And then the last is real-time implementation can be a challenge. One of the goals in informatics is to hit the real-time implementation with the right person, the right time, the right information. And so these all just need to be planned in advance. So I'm going to step into some NLP implementations that we've done, along with a brief description of things to incite discussion about what the future might hold. But I want to take a step back because I'm based at a pediatric institution. So let's examine how pediatrics might be different. About 20% of the United States population is pediatric. Are they really just tiny adults? No, unfortunately, they aren't. Eventually, they'll be adults, but not while we're looking at them. And so they have more developmental stages. And so from the genomic side, what this means is that genetic changes may occur throughout the child's development. And so things may need to be rerun and reevaluated. They have a lot of variability based on age that's not necessarily apparent in an adult side. So for example, a vital sign varies by age. A temperature of 100.8 degrees in a neonate may be cause for concern, whereas if I come in as an adult with a temperature of 100.8 degrees, nobody is all that concerned, and really, why did I go in necessarily that day? And then the other thing is there are different modalities of care delivery. So medication dosing is frequently weight-based in pediatrics, whereas it's not on the adult side. And so this adds a whole new layer of things to think about while we build our decision support in the end. So more of the stuff on machine learning research in pediatrics. One of the issues, of course, is an added interaction layer because it's the caregiver, not the patient, that might be performing a required or suggested treatment. The patients are fairly not autonomous yet, and so they are not the only ones participating in their own care. Another is that there's multiple historians for medical histories. So it's not just me saying, here were my symptoms over the past 3 weeks, but it could be any caregivers, including mom and dad, family members, or someone else, and the patient as they get older, and all of these different lines need to come together to make a cohesive narrative, and which is a challenge for the pediatricians, but also a challenge on the machine learning side. And then the last thing is that there can be a dynamic patient history due to development. Adult trajectories are typically more stable. So it was important to note and to report when my child was between 6 and 12 months of age, what solid food he ate, that he ate solid food, and how he tolerated it. However, now at about 11 years old, it's currently pretty much entirely unremarkable that he's eating solid food and will remain so for most of the rest of his life, unless, as a mother, it's a vegetable, in which case that's great and important for me, but not necessarily as important for his provider. So do all these things impact machine learning research? They do. But the applications of machine learning in pediatrics is continuing to increase. And so machine learning has been applied in pediatrics in sepsis identification, both in the emergency department and in pediatric intensive care. Machine learning has been applied with pediatric intensive care unit transfer to identify people who may have appendicitis, to identify patients who may be eligible for epilepsy surgical consults, which I will talk about briefly, and to identify patients who may be suicidal. So let's go to a couple of projects that we've done and kind of steps through things that have happened in machine learning in pediatrics. And so I have 4 main categories here, and each of these represents kind of a project to go through. And the first one is healthcare decision support. The second is provider decision support. The third would be integrating NLP with patient encounters. So it's still provider decision support, but it's directly involving the patient in their care. And then the last one is more of a future look at precision and predictive medicine and what's going to be coming up. So for healthcare decision support, what's important here is that we made a real-time identification system to screen patients who may be eligible for enrollment in clinical trials during their emergency department visit. And what's really important to know here is that there is a lot of retrospective background and work that goes on prior to something being implemented prospectively. So in our case, starting in about 2014, we started working with end users and looking at data to design this implementation that would be helpful for them in the emergency department. And our end users here were primarily clinical research coordinators, who I'm going to call the CRCs. So first, let me tell you about the CRC's old workflow method, then I'll describe our system, and then I'll tell you about their new workflow method and let you know whether or not this was effective. So what they did was the clinical research coordinators could sit and look for patients who were coming in, check for their structured data, such as their age, their chief complaint, things like that, and then look back at their list of clinical trials they're currently enrolling, see which ones the patients might match up with, and then do kind of a further dive into their electronic health record before they approach them for enrollment. So what we have here is we developed a real-time natural language processing system with the idea being we can do the structured data for you automatically. And we can do some of the note data as they're filed automatically as well and save you time and hopefully increase clinical trial enrollment and certainly clinical trial screening. So this top part here is our EHR database, the database looking structure. And so we have structured and data entries and we have unstructured clinical notes. This green part in the middle is the ACTES module, and it includes all of the NLP, the patient identifier, and a web-based dashboard, which I'll show you on the next slide, for the clinical research coordinator to use. So what happens is we do the same thing. As a patient comes into the emergency department, we identify the patients using the structured data and using unstructured clinical notes as they're filed. Then we display them on this web page for the clinical research coordinators to make a decision about whether or not they should approach them or not. They can annotate the patient's eligibility, they can annotate the screening, basically they can aid in communication across all of the different clinical research coordinators. And then ultimately, whether or not they decide to approach the patient, they can then document whether or not the patient was enrolled or if the patient was not eligible at all for this study. In which case, all of these data come back into the NLP and it performs active learning and we improve our recommendations for next time. So here's what their website looks like. What you see here is it's color-coded for the 5 clinical trials currently being enrolled in our emergency department. What you also see is at the top right of that box is the time it was last updated. So it's updated approximately every 15 minutes, and all new notes that have been filed since then are included in the processing and the new recommendations are made. So when a clinical trial associate wants to look at, say, in this case, the Healthy Family Study, this is what they get. They say, here is the top ranked patient. Their rank is number 2. Here's what room they're in. Here's their name, their age, their gender, their chief complaint. Here's their attending in case you, the clinical research coordinator, need to approach them. Here's why we think they're a great match for this study. That's what the HIT term is. Here's their length of stay in the emergency department. So you can kind of decide, perhaps they're going to be going home soon. Maybe they just got here and they need some time to make sure nothing else happens. And then here's their official patient status from the EHR. So if the clinical research coordinator says, yes, but this patient doesn't match and we don't want anybody else screening them again, they can click that little remove button. And what the remove button lets them do is say, this patient's eligible, therefore I enrolled them. And so they don't need to be on this list anymore because we don't need anyone else to talk to them. This patient's not eligible. I approached them, but they declined, etc. So what this does for them is it lets them have aided communication. It lets them spend less time going into the EHR and basically gives them a different place to view patients and see how they're doing. So the question is, did it work? And the answer is yes. And so what we have here is that the top bar is without the ACTES system in place over a full year, and the bottom bar is with it in place. And what happened was that we had a 30% reduction in screening time, even when adjusting for the seasonal variation that comes with being in emergency medicine and patient visits. So this is great. And so what this means for us is that we can continue to expand it and add more studies. But it also means it'll help aid us in planning future research studies, finding patients who might be eligible, and future staffing. So let's talk about something that's provider decision support. I'm going to do a brief background here for you on epilepsy. So epilepsy is one of the leading neurological disorders in the United States, and it affects more than 480,000 children and over 2 million adults. 30% of patients with epilepsy are intractable, and intractable epilepsy means that you have drug-resistant epilepsy. So in other words, the medications don't control your seizures. And so of these who are intractable, 55 to 60% of the children are eligible for neurosurgical evaluation and treatment, and they're seizure-free after they've had appropriate neurosurgery. And of those, 77% have an improved quality of life with appropriate surgery. Currently, the average here at Cincinnati Children's from diagnosis to surgery identification is about 6 years. Our goal with the PESTION lab was to develop and create a natural language processing algorithm that used the clinician notes to differentiate between intractable and non-intractable seizures in children. So here's the way this one works. You can see on the bottom, we have the patient identified at year 1. This was their date of diagnosis. And then year 10, we can pretend this is how they are today. So what we have here in the top is the neurologist language of intractable seizures as they write their notes. What we have here at the bottom is the neurologist language of non-intractable seizures as they write their notes. And these are just general trends for the way they write their notes. Each of these little E's represents a patient visit with their neurologist. So you can see that as they go through their care, they're moving towards non-intractable. No, this patient is moving towards intractable. So what happens in the previous visits, prior to implementation of our natural language processing algorithm, patients can be identified at year 6, and we say, look, you're intractable, you may need to be sent for surgery consult, let's go ahead and send you. Instead, with the algorithm and alerting the providers, we can recommend and find patients at year 4, so up to 2 years earlier than they're being found in typical clinical care. And so what we wanted to do with this was then implement it into clinical care. So here I'm going to give you a brief description of like our real-time implementation. So what we did is every Sunday, we ran through all patients that we knew who had epilepsy who visited our clinics, and we looked for patients with an upcoming visit that week. We did it all on Sunday so that when we sent an alert to providers, they had plenty of time before their patient visit to read through the chart, to look at things, and to think about the recommendation we might be giving to them. So what we did is we evaluated all of the upcoming visits, and then we assigned a score. And in this case, on this page, the scores go from about -2 to 2. This is one set of patient scores from January 2017 to October 2017. And you can see that as this patient gets a new score every week, they appear to be moving towards being intractable. And so what we wanted to do was we set a cutoff on our algorithm to maximize the performance that we had, and then we sent a reminder to the provider with information. And it said, you know what, your patient may be eligible for neurosurgical evaluation. You know, you should think about going ahead and sending them. Providers received about 1 to 2 total alerts a week. And that's about it. So we looked at our area under the curve because we developed everything retrospectively with the neurologist, and then we wanted to evaluate it prospectively. And we did a good job. We have 82% for area under the curve. Our positive predictive value is low. It's only 40%. Our negative predictive value is very high at 97%. What that means is that we're probably not missing anybody. And our number needed to screen is 3.6 patients. And that means that we need to look at 4 patients to find 3.6 patients, to find one who is going to be eligible to be sent to surgery consult and ensure that they can be sent. So we did that. We prospectively evaluated 200 different patients that we identified from October 2017 to October 2018. And we had 2 epileptologists look at every single patient and say, yes, they should be sent based on just their clinical data, or no, they're not really going to be surgery candidates. So of the 200 patients, 64% of them had drug-resistant epilepsy and were eligible for surgical evaluation. Of the 128 that were identified, about 58% were likely not going to be sent to surgery ever. There's a wider range of reasons listed below, but including the surgery probably would not substantially increase their quality of life. 6 patients had already been evaluated for and had undergone surgical treatment, but they were still having seizures. And of course, then things like social issues where the patient and family were comfortable with the current level of seizure control and were interested in sending their child for surgical evaluation. 36%, and that's all, were true misclassifications and didn't have drug-resistant epilepsy. So this allowed the providers to make a better decision. when they saw their patient, they had this additional information and they could say, well, here's one of the decline reasons. This is why we don't think this patient's eligible. Or they could say, you know what, go ahead and send them. So we've improved surgery detection by about 43%. And so decision support is great and it's very important. But what about things that are more directly patient-facing? Like how do we include the patients in their own care? And so here's a brief background on suicide, which is suicide is a major public health problem. Patients with a suicide attempt have frequently presented to the emergency department or an ambulatory clinic up to 2 weeks prior to their attempt. And these patients can be identified through verbal and nonverbal markers, including video, audio, and linguistic features. What I have here on this slide to show you is an application built by Dr. John Pestian for automated suicide detection in schools. So John is doing a large multi-center trial to predict repeated suicide attempts in adolescents. He uses video, audio, linguistic, and genetic features to help predict a patient who may make a repeat suicide attempt. He built a large corpus of suicide notes, about 163, and is working on this larger prospective trial, which is what's in the figure, with the Cincinnati public school system. So let me show you what's happening because I don't have any results for this one yet. What happens is a therapist or a guidance counselor is able to interview the patient. They can sit and talk to the patient and record the interview, and they use a structured interview typically. Then they can perform annotations about who was speaking at each point in time and what was said and what's important and not important in the conversation. All of these data are sent up to a cloud, processed, and returned with basically a stoplight approach to risk. So either they are high risk or they are low risk. And if they are high risk, what can we do to provide them with additional resources now to ensure that nothing bad ever happens? This is currently being evaluated in all of the Cincinnati public schools listed on the image to the left-hand side, and is working with the guidance counselors there. And hopefully we'll have great results by next year to talk about. So this is a great step in involving real-time machine learning, patients, and the community all together to help improve some of the care. So the other item I wanted to bring up that gets us towards the future approach to the way things are happening is precision and predictive medicine. So what about patient-specific recommendations? One of these is, will this drug give me a heart attack? I've picked two papers here. One is from 2008, one is from 2012. So this isn't necessarily new research. It just needs to be expanded upon and continue to improve, and especially in pediatrics. What about the idea of what medication should I take? And so precision medicine. And so this has been done too on the adult side. So this is which will this drug give me a heart attack? Then what's the other one? Like, can we predict future outcomes from the data we have in the EHR now? And this is the machine learning for personalized medicine, predicting primary myocardial infarctions from electronic health records. This particular case is not a great example for pediatrics because there aren't a lot of MIs in pediatrics, but there are other things that we could predict as well. So these avenues are actually best served by something like deep learning, which does prediction and additional recommendations directly to the patient and or their provider. So the answer is, what if the algorithm could adapt the way a human could when presented with new information? So like a driverless car that can be efficient, or providing preventive health care based on all the previous information. What do we need to be able to do these kind of new and interesting things going forward? Well, we need data and we need computing power. The example I put down here was for big data and data mining. One of them is the NIH All of Us program, which seeks to collect over 1 million patients and include lots of different pieces of information, their hospital records, their genomics information, as well as patient surveys. And the idea is that we'll have a large, rich data source to do some of these larger pieces of evaluation and prediction in the future. And so what does the future hold? And unfortunately, I only really have questions to leave with and not answers. One of these is potentially large de-identified data sets. So we could draw larger and potentially more accurate inferences if we had larger data sets with more people that were more representative of the entire population. One of the goals with the epilepsy machine learning would be to take it and apply it both to adults and to other pediatric children's hospitals. We know it does a great job here, but can we make it do a great job other places and improve care everywhere? Large de-identified data sets would help us with multi-center informatics trials. They'd help us expand our reach of things we've all developed. Another would be the addition of other data sources into clinical data, so patient-entered data. So I entered a survey in before my care, and that should be included as well. Another is device entered. Those could be medical devices, such as your glucose monitoring from your insulin pump, or they could be someone's pedometer data. Maybe these data predict something that we don't know about because we don't have large-scale sets of device data combined with electronic medical record data. And another one of these would be to focus on patient-facing applications. So how can we encourage patients to be participants and stewards in their care and their own health? What else could we design using these larger data sets and using these patients for what is it that a patient wants on a general day? And how could we make use of some of these upcoming algorithms and improve technologies to further clinical informatics research and ultimately to improve patient care and health in both the pediatric side and the adult side? And so these are the questions I'm going to leave you with. One of the things I want to point out in all informatics research is that my acknowledgements here barely scratch the surface of the number of people who have talked to me and have helped me with things, and also that you collaborate with across a wide variety of fields to be able to work with not just providers and application developers, but patients and the community and everybody involved. And so I'm open for any questions. I want to point out that I thought I would be super clever with my slides and have some kind of cloudy, wonderful picture to show how great I was, but I didn't, so this is what you get. So that's it. Are there any questions?
Thank you, Judith. That was wonderful. And yeah, if you guys have questions, please go ahead and enter them into the questions queue on the GoToWebinar control panel. We do have a couple already in the queue. I'll go ahead and read them aloud and give Judith an opportunity to answer. So Judith, the first question we have is, what program did you write the natural language processing script in?
So we are in the process of rewriting that script, and I think it will end up being in Python in the end. It was written in 2 or 3 different languages, and we're working on cleaning it up a little and putting it back together a little, and so the answer I'll give you will be Python.
Great. Second question is, out of curiosity, how are recommendations/predictions from machine learning typically received by physicians/patients?
So far, I have never had a problem with anyone and they're having a debate, say, with their recommendations from a machine learning application. I am sure it's coming. I would say that they were generally received well. Frequently, one of the issues we have, like with the neurosurgical consult, is there are other reasons why that patient hasn't been referred for surgery and they just aren't in the EHR. So if there are social reasons that for any reason aren't recorded, then the provider says, no, I would never send them because of X, Y, and Z, but I also might not write that down in the record. And so what we did to combat this for study purposes is we asked them to say, if you want to say no, would you please tell us why? And that way we can design something better going forward. On the patient side, I have not heard of any fallback from patients either saying, I don't agree with this recommendation and I don't think this fits me. But the other option, of course, on the suicide application is we are referring you and ensuring that you get additional resources. And so you have a fallback and you could talk to that therapist and say, on a more personal level, I think it's okay because of X, Y, and Z, and we're out of the picture because all we've done is try to send you in the right direction.
Great. Next question is, how to gather data sets? Are there any public data sets?
There are some public data sets, and MIMIC is a public electronic health record. The NIH has several public data sets, and there's a lot of research being done on like the Medicare data, because you can get large amounts of billing data, and so you have a great knowledge, and it's pretty accurate about what was actually done during care. The more difficult thing about gathering large data sets, of course, is the notes, because they're difficult to de-identify, so they're difficult to share publicly.
Great. Next question is, how about the research on structured data? Are there any opportunities?
Yes, there are lots of opportunities for research on structured data. And one of my graduate students who has done a lot of work has also looked into some of the epilepsy pieces with purely structured information to see if it performs as well as, better, or worse than the natural language processing, as well as there are other published papers using only structured data. And one of the great things about structured data is almost everybody has it and almost everybody can access it.
Wonderful. This next one is a little long, so bear with me. As security is a big concern today, can you comment on what steps are being taken and what steps you envision that need to be taken to protect information, as well as to protect the workings of the system itself from attacks such as ransomware?
So, yes, I can do my best to answer it. One of the ways things are protected on the hospital side is that we run things entirely within the hospital. And so security is already taken care of. Security is very tight. There is, of course, always a risk. Nothing has a non-zero risk, but there aren't public-facing websites to get things back out of. This is, of course, not going to be as effective of an issue if what we want is public-facing websites to help include the patients in their care. What I can say is that what we have to do is do the best we can for authentication with the patients and security, and decide what the best way is moving forward to ensure that nothing is ever accidentally shared, and at least alleviate those worries.
Great. How could you directly involve patients in clinical care and with decision-making using algorithms?
So patients can be involved in a lot of different ways. One of the ways they can do this, and I am so happy because I have a slide prepped. So Vanderbilt created this tool called the Flu tool that they used in 2010 to 2011, and they used it with their personal health record. And so patients could enter their diagnoses, they could step through some questions, and they could be given whether or not they needed to call and make an appointment advice. So fairly innocuous advice in an already secure environment, and they could say, I'm having these issues, here's what we think we should do. This is actually a direct application of patient involvement in the decision-making process, because they also get to make a decision, and they need to seek out and find what it is they need, what information they want, and then decide whether or not they need to call and make a phone call as well. This would be kind of a step before, say, a nurse line. Like I might go through and want to check all of this information and say, yes, maybe I do need to call and make an appointment, and then call the nurse line and make a decision from there. Or, because all of this is Amazon-based, imagine the joy if you could ask Alexa these things, and Alexa could say, do you know what? Do you want me to go ahead and call your provider and try to set up an appointment with you? And you could say yes.
Fantastic. One more final question, and then we'll end the session. How could or should I go about getting into the field of informatics?
We always want more people. The field is only going to grow as things go. And so if you're starting from the undergrad standpoint, I would suggest looking at both computer science and some of the basic biology courses, which is, I admit, what I did to start towards informatics. There are lots of institutions now that offer informatics as an undergraduate degree. I would be remiss not to offer that we have a graduate program here at the University of Cincinnati in biomedical informatics. But it's not just us. There are a lot of graduate programs that offer masters and PhDs in biomedical informatics across the United States that you could talk to and enter and decide if you wanted to do research or if you wanted to work on some of the informatics pieces and then move into industry.
Fantastic. Well, I want to offer a huge thank you to you, Dr. Judith Dexheimer, for your time today and all of the valuable information that you've provided during the session. I also wanted to let those of you attending know that we have our next session coming up on August 29th from 9 to 10 a.m. Pacific time. It will be with Dr. Susan Gregoric, Director for the Division of Biophysics, Biomedical Technology, and Computational Biosciences at National Institutes of Health. And the session will be about National Institutes of Health their strategic vision for data science and enabling a fair data ecosystem. Thank you again, Judith. Thank you all of you for attending. We hope to see you next month during our August session. And please find us on the AWS Education Research Seminar Series, where you can also find Judith's slide deck and additional resources, as well as the recording of this session and previous sessions that we've held. Have a great rest of your week, and we hope to see you again soon.
Thank you.